Hey guys, it's Ryan. In this video, we're going to talk about operative dentistry. So operative dentistry is the bread and butter of the dental field. Ideally, as dental professionals, we want to prevent cavities from forming by focusing on preventive measures like regular 6-month cleanings, fluoridated toothpaste, but sometimes it's unfortunately too late and something needs to be done to remove active decay and fill the hole with some adequate filling material. So, in this video, I'm going to give you a quick overview of operative dentistry, some of the instruments and materials used, some of the procedures, and some important terms along the way. So, here's a list of some common procedures done in operative dentistry. Have enameloplasty, sealants, preventive resin restorations, class 1 and 2 composite and amalgam restorations, partial caries excavation and indirect pulp capping. These are just a few of the procedures that I'll be talking about probably in part 2 of this video series. So first, let's talk about some basics. So G.V. Black, known as the father of modern dentistry in the US and also the father of operative dentistry, came up with this classification system for fillings. So we have class 1 through class 6 and some images on the bottom here. And so class 1 is for basically any surface that involves like a pit or a fissure. So you can think of all the cracks and crevices on the occlusal surface or the biting surface of a posterior tooth. And then we have like the lingual pit areas and the incisors on the lingual or tongue side. So the occlusal of posteriors or the linguals of incisors would include that would be like a class 1 filling if it involved those tooth surfaces. Now class 2 involves the proximal surface of a posterior tooth. So if you had a mesial surface that had some decay and you also included the occlusal surface, that would be considered like a class 2 restoration. It could also involve both proximal surfaces, so it could involve mesial and distal, and then the occlusal connecting the two. That would also be a class 2 restoration. Class 3 includes the proximal of an anterior tooth. So similar to class 2, except now we're talking about incisors and canines. Class 3 does not involve the incisal edge, where class 4 is basically like the corner of an anterior tooth. So it's involving the incisal edge, but also the proximal surface. Class 5 is another common filling done. That involves the cervical third or the gingival third of either an anterior or posterior tooth. Class 6 only involves the incisal edge for an anterior tooth or the cusp tip of a posterior tooth, and these are a lot more rare. But for coding purposes, we don't go by the class 1 through 6. You go by material used, whether you used amalgam or a resin-based composite material, if it was the amount of surfaces that were involved, and if it was an anterior or posterior tooth if you were using composite. So let's say you did a mesial occlusal filling or an MO filling on number 19 and you filled it with amalgam. This would be a D2150. It would be an amalgam 2-surface restoration, and you'd code it as such. So for preoperative procedures, this is referring to things that you should do before picking up the handpiece and doing any operative dentistry. These are some of the things we like to do, and this is an acronym. I feel like it's a good way not only to remember the steps, but a great order to perform them in. So OASIS is this acronym that I remember. It stands for occlusal contacts, anesthetic, shade selection, and isolation. So for occlusal contacts, this is relevant for any restoration that's going to involve like a biting surface that's coming into contact with an opposing tooth. So you always want to check this at the very beginning of the appointment, and if it's contacting an opposing tooth, you want to keep this in mind, because when you restore it, when you fill that cavity up, you want to make sure that it's a consistent contact, and it's not what you might tell the patient. You don't want them to feel like it's high in occlusion, or they're biting on it earlier than all the other teeth, because then that can cause some periodontal problems and so on. After checking for occlusal contacts, you can deliver your anesthetic in the proper block or the proper local injection that you need to do. You can also check shade selection if you're doing a composite tooth-colored material. And you want to do this basically before you isolate the tooth, or before you do any operative procedure, because when the patient's leaving their mouth open and you have like cotton rolls in their mouth, their teeth can tend to dry out, and when that happens, they dehydrate and become lighter in shade. So if you waited till later to pick your shade selection, you're probably not going to be as accurate to their actual tooth color as if you did it at the very beginning of the appointment. And then lastly, you can use a rubber dam or use cotton roll isolation or an isovac to isolate the area that you're working with. So that's Oasis, and here's an Oasis from probably one of my favorite video games of all time, Paper Mario on the Nintendo 64. I had to throw that in there. So preparation is, and we can talk more about this in another video, but the word preparation refers to what is colloquially known as drilling, where you use instruments to cut out decayed tooth structure, and not only that, but design it in such a way that it doesn't only remove all the bad stuff, but leaves adequate good stuff that you can fill or restore. That's the more dental terminology used. You can restore that tooth material that you removed. So there are three main principles for preparing a tooth, doing a cavity preparation on a tooth. The first one is that all faults or caries should be removed. Caries meaning cavities, and this is kind of a given, but for this example, this is kind of like a very severe example. Usually it's not this obvious, but this is all the soft material that's kind of easy to remove, and obviously this all has to go. But not only that, all friable or weakened enamel should be removed as well. So this we're going to talk more about in the next slide. So that's going to involve mostly all of this material. So not only the decayed stuff, but also this stuff at the end. You can kind of see this explorer tine is going in here, and you can see it peeking through here. So you can obviously see how there's just a hole through the proximal surface of this tooth, and that all of this enamel up here is basically just kind of floating in thin air. So that's unsupported and needs to be removed. Also, all margins should be placed in a position to allow good finishing of the margins of the restoration, meaning that you don't want to go too far below the gum line. You don't want to go too subgingival, because it would be very difficult to finish the margins of the restoration. You could have an overhang or have a gap between the restoration material and the tooth material, the tooth structure, and that can make it very easy for plaque to accumulate and for bacteria to travel into that gap. Also, you want to make sure that you can access the sides here. So when you fill up this this cavity here, you can access these side margins, and also again polish them, finish them properly, so there aren't big ledges and big gaps that you could have leakage through. So you want to allow enough clearance between this margin and the adjacent tooth. So enamel is obviously very critical. It's the outermost layer of tooth structure, and it can't grow back. So when we're drilling, we have to be mindful because it's essentially an irreversible surgery what we're doing. Once enamel is removed, we can't grow it back. Um, and important words that I use throughout this presentation are going to be in red, so I'll make sure to highlight those when I go through. So basically we have friable enamel and unsupported enamel. They both need to be removed, but they're different terminologies. They're used to refer to different types of enamel. So friable enamel is talking about the state of mineralization. I have a video on my channel that talks about like what a tooth is made out of. It's basically like a ceramic that's made of mineral like hydroxyapatite, and when the enamel is attacked by bacterial acids, the mineral is dissolved, starts to dissolve, and the enamel becomes porous. And instead of looking translucent, it starts to look a little bit like chalky white. And this is, we're starting to get into friable enamel territory, and it needs to be removed not only because it's weaker and it's more prone to further damage, but the bonding agent when we fill the tooth won't be as effective. Now, unsupported enamel also needs to be removed, but for a different reason. This is talking about its attachment to the underlying DEJ, which stands for dentino-enamel junction. This needs to be removed because there's no underlying dentin support to support it under cyclic loading. So basically what we have here is we have our dentin layer in this white, and we have enamel with all these sorts of striations. And so what these are, they're representing enamel rods. And this is when a tooth is developing, you have ameloblasts that start at the DEJ and they move outwards. And as they do so, the ameloblasts secrete enamel or different amelogenins and enamelin, these different materials that eventually form enamel. And this is just like a one-time process. And as they move in that trajectory, they form these actual like crystalline rods. So this is a pretty accurate example of what they actually look like. And now if we look at what B is pointing to, B is basically the ideal enamel margin. So figure a dentist drilled in their cavity preparation, and this is the ideal enamel margin. It's composed of full-length enamel rods supported on the cavity side by shorter enamel rods, all of which extend to sound dentin underneath. So you can kind of see how all of these here are all full-length enamel rods, and then as we get to this point, they're just shorter ones, but they're all connected to underlying dentin. So now let me restart this drawing. And I want you guys to look at this. If I, instead of doing the preparation like this, let's say I went at a very sharp angle, something like that. Now you can see what happens. Basically, if I cut into the tooth at a really sharp angle, I leave these enamel rods all in this area. If I get a different color here, all of these enamel rods are basically floating in thin air. There's nothing. I removed all of this tooth structure down here, and they're not supported by underlying dentin. So that's what we would call unsupported enamel. So that's why we want to be mindful about how we cut our preparations. We want our enamel to always be supported. And now if we go to A, this is, we're kind of talking about, with B, we're talking about on the occlusal surface. On A, now we're thinking about, what about if we're drilling into the facial or the lingual surface of a tooth? Well, you can notice how for B, the walls of this prep were sort of, they look kind of parallel, maybe a little bit convergent, meaning that they move towards each other as you go outwards. But for A, if anything, they're divergent. They kind of separate from each other as you move out towards the surface. And that's purposeful. That's because of the orientation of the enamel rods. So, say for example, if we were to do the same convergent design and we cut it like this, Now you can see again, we're going to have unsupported enamel if we cut at the convergent angle. So basically, we have to orient our preparations in a certain way depending on where we are in the tooth. And basically, enamel rods are perpendicular to the DEJ, so you can just keep that in mind depending on where you are on the tooth. So another important word is the cavo-surface margin. And basically what this is if we dissect the word cavo for cavity and surface for, well, tooth surface, it's basically the junction between the cavity wall and the external surface of the tooth. And basically these two surfaces form an angle, and that angle should ideally be greater than or equal to 90 degrees. And that's our basic rule for preventing any unsupported enamel from being formed. So you can see how these angles here are all 90 degrees or greater, and the ones I drew in up here, this is like an acute angle that would not be ideal for your preparations. So, sorry, a little bit technical there, but I think it's interesting, and it's a very important concept that's talked about in dental schools and also appears on dental board exams. So let's talk about some instruments and materials we commonly use in operative dentistry. So burrs are a carbide. These are carbide burrs. They're made of tungsten and carbon. They also come in diamonds, available in similar shapes and sizes, but are different. In one way, they're more expensive, but also they provide a rougher surface that abrade rather than cut. So usually for like soft tissue surgeries, you're going to pick a diamond over a carbide burr because the blades will likely pull on soft tissue and cause more bleeding, whereas a diamond abrades and cauterizes and doesn't cause as much bleeding. But there are different uses for each kind of instrument. So these burrs here are friction grip burrs. They'll lock into your high-speed handpiece without any latches. This is the 245 is a very common one. It's pear-shaped, meaning it's slightly wider at the bottom than the top. Resistance form and retention form are some more important operative terms that refer to the design of your preparation. And the burrs are designed in such a way that help you facilitate good resistance and retention form of your preps. So you can see, it's kind of hard to see, but the bottom edges of these burrs are rounded, and that's so you can provide rounded internal line angles. Basically, the corners of your preps, the inner aspects, like these areas here in these corners, are going to be rounded, and we always want that because any internal line angles that are sharp are going to be areas where stress can accumulate and fractures can occur. So we always want to round all of our internal line angles. And this pear-shaped design also allows for occlusal convergence, like we were talking about for our coming in from the top surface of a tooth. For something like an amalgam that can't be bonded into a tooth, this is necessary to prevent the amalgam material from being dislodged and coming out. 330 is another burr design. It's just a smaller variety. It's not as long. Here's a Bur Block. It has a whole bunch of other burrs. You can see here's the 245 and the 330 we just talked about, and then there's round ones, or egg-shaped ones, footballs, flame-shaped, a whole bunch to pick from. Finishing burrs are a little bit different in that they have more blades. So the cutting burrs may have 6 blades, whereas a finishing burr might have 12 blades, which means it won't cut as easily. It'll be more of a more gentle cutting of enamel and dentin. All right, so etchant is another very common thing dentists use. It's a very strong acid, but it's used in a very controlled way. Obviously, the teeth are isolated. It's not going to be contacting soft tissue. And it provides for this bonding. It provides for adhesive dentistry, which is basically the whole concept behind how composites can work in filling a tooth structure. So the acid etched enamel bond is incredibly powerful. This is just a quarter of an inch diameter, gives 20 megapascals, which is a huge amount of pressure, a force over an area. And for the acid etched dentin bond, it's much less predictable. It's not quite as predictable as the enamel bond because instead of these enamel rods that we were talking about, dentin has all these like wiry, noodly like collagen fibers that are just a lot less predictable. And also there's this stuff called dentinal fluid that is inhabiting that dentinal tubule space. And so that can, like saliva or blood, contaminate the adhesive interface, which can be a problem for bonding in general. So when we use etch, we really want to make sure we're getting it on the enamel. Sometimes you just selectively etch enamel and don't worry about the dentin because this bond isn't as reliable. So what does it do? It demineralizes the enamel and dentin. It basically does what bacterial acid does, but in a much more controlled way, of course. And it creates a spongy, low-energy surface that is perfect for primer and adhesive. So primer is our next step. If we were talking about doing this as a process, after the etchant, we would place the primer, which is sometimes HEMA, hydroxyethyl methacrylate is what it stands for. And this hydrophilic group with the OH will face down into the dentin or the enamel tooth structure with the hydrophobic end facing up. And this transforms the spongy low-energy surface into a high-energy surface, and that's basically the priming process. And usually there's some type of carrier that carries this monomer, so ethanol is a common example. And that's why when we use the primer, we want to use like a gentle stream of air to dissolve the carrier once the primer is rubbed onto the etched tooth surface. And then we use adhesive or bond, which is filled with bis-GMA or another dimethacrylate, and HEMA. Basically, it's like a double stick tape that sticks between the tooth structure and the composite filling material to be placed. Now, usually, or what we use is a combination of the primer and adhesive in one system. This is like the 5th generation or one bottle system where they put both the primer and the adhesive in a single solution. And what happens is once you etch, here's dentin for example, it leaves these little like micromechanical lock features so that when you place the adhesive, it can link into these spaces and form the hybrid layer so that the composite can bond via the adhesive layer to tooth structure. Now, composite resin here is basically like a history starting back in 1958, and there's a whole bunch of different types of composite resins with different filling percentages and percentages of filler versus resin. So we can skip through this part. It's a little too technical for the scope of this video. Composite resin is indicated for small to moderate lesions. It's of course great for aesthetics because you can match tooth structure relatively well, at least better than with an amalgam material, with a silver filling material. It's also good if a patient was allergic to one of the components of amalgam. Now, contraindications, as I mentioned before, if it's hard to isolate, if it's like an area that's close to the gum line, or it's like way in the back and it's hard to get good isolation. Saliva and blood and dentinal fluid as well can really make the bonding process much, much harder. And it makes it very difficult for the composite to bond to tooth, and then you can get leakage and problems. So you don't want to mess around if it's an area that's very hard to isolate. It's also not as strong as amalgam, so posterior composites are generally much more technique sensitive than amalgam, and clinical trials show that the more surfaces that are involved in a composite, especially for posterior teeth, the composite's more and more likely to fail. So that's one thing to also keep in mind when you're deciding between like a composite resin or an amalgam filling. And then what the heck is this C factor thing? So it doesn't stand for composite. It actually stands for configuration factor or cavity configuration factor. And it's the ratio of bound to unbound surfaces of the composite. So if you're bonding to only one surface, like if you're doing a sealant or a class 6 restoration, which is what we talked about before, if you're bonding only to an incisal edge or a cusp tip, that's like, if you think of it like a cube or a die, it's basically one surface that is touching a tooth, and all the 5 other surfaces are unbound. They're just contacting air. So if you think of it like a dice or a cube, this number is always going to add up to 6. If there's 1 bound surface, there'll be 5 unbound. If there are 2 bound, there'll be 4 unbound, and so on. And so so that's one way to remember this. And you can also remember how the looks basically almost the class number, class 1, will match up with the number of unbound surfaces. So that's kind of a cool way to remember. Class 2 will have 2, class 3 will have 3, and the only exception is class 6 will have 5. But the higher your C factor is, so the more surfaces that are being bound to tooth structure, the more you have to worry about polymerization shrinkage. Basically, as the composite is cured with a curing light, it undergoes this thing called polymerization shrinkage, which means that the material shrinks away from the tooth walls, and so you can have leakage problems and so on. So what do you do about it? Well, you use smaller increments between each cure. So you do 2 by 2 millimeter increments at a time, and then cure those, so you don't have to worry about placing one huge increment into the entire cavity and then curing it all at once, so you can have some shrinkage problems with that. So for the light curing, this is actually a very important part. I think it's kind of skipped over in a lot of classes and so on. It's kind of looked as, oh, I can just do something else while I'm curing and look away, and it's actually a very critical process to the survival of and the success of a composite resin restoration. And that's because there's a lot of studies done that show that you get a higher failure rate in posterior composite resins as compared to posterior amalgams for this reason, because you get weaker structural features when you don't cure properly. So we already talked about using increments at a time. You want to be as close to the filling material as you can without touching it. You want to be angled properly, so you can be perpendicular to the surface that you're curing. And just keep in mind the manufacturer's recommended time, the composite that you're using, and that all of those things match up and work well together, because some lights are meant for some composites and some lights are not meant for other composites. And that's because there's usually a photo initiator, like camphor quinone is used in a lot of composite resin fillings today, and it has a light absorption spectrum between 400 and 500 nanometers, So if you're using like a third generation LED, light curing unit is pretty popular today. That's going to do a good job because it's giving off a narrow spectrum of light at 470 nanometers, which is within that absorption spectrum of the photoinitiator. So those are just things to keep in mind when you're using certain light curing units and certain composite filling materials. So we can just skip through this. That's just some history. Basically, the indications are the opposite, and the contraindications are the opposite of what we had in composites. So it can deal with biting forces better. If there's an area that's hard to isolate, amalgam, it doesn't really matter if it's not isolated super well. It's obviously not as aesthetic, and so on. Radiography, I just want to mention, it's just interesting to note the kind of spectrum from most radiopaque. So you can see like here, because you're constantly looking at x-rays in operative dentistry, these materials here are the most white. Those would be the amalgam fillings, and the darkest, most radiolucent structures are the pulp chambers and pulp canals. And this is just a fun fact. You have to lose about 25% of enamel mineral before you can even see a radiolucency on the x-ray. So in other words, if you're already seeing decay, like here, for example, I can kind of see what looks to be a proximal lesion here already into dentin. The actual disease is 25% worse than it appears on an x-ray because it doesn't show up until basically the disease has progressed to a certain point already. So tooth preparation, we've already kind of talked about this a bit, but all preparations must correlate with physical properties of the restorative material and anatomic structure of the tooth. But ultimately, and this is our first rule of tooth preparation, the shape and size of the tooth preparation will be determined by the defect. So we can have all these rules about how to design a preparation, how to have all the line angles this way, and the unsupported enamel and all these things, and those are all important rules. But if you have a big cavity, I mean, you're going to have to drill out a lot of tooth structure. That's just kind of how it works. So it's the ultimate determinant of what your tooth preparation looks like, whether it's class 1 or class 2, is determined by the size of the defect. And if it's really big and it's already extending into the pulp, you have to let the patient know, like, look, this could be a root canal down the road. We're going to try everything we can. But it's just something to keep in mind that depending on the extent of the defect, that's going to determine how you prepare this cavity. And then the last thing I was going to mention here is that adhesive dentistry, where we're talking about using the etch and the primer and the bond, allows for much more creative prep designs. So conventional preparation is like going 0.2 millimeters inside the dentino-enamel junction, having a universal pulpal depth, all of these rules and stuff. And with a modified preparation, basically, because we have this etching, this really powerful enamel bond with acid etching, we don't necessarily have to be uniformly inside the DEJ and all this stuff. We can more focus on removing the decay that's at hand and taking care of that, and also conserving as much healthy tooth structure as we can, not just removing tooth structure for the heck of it. We just can take out the bad stuff and leave the good stuff. And the goal is really to save as much viable tooth structure as possible. Alright guys, I think that's where I'm going to stop this video for now. In part 2, we can start talking about some of these commonly performed operative procedures that I talked about earlier. Alright guys, thanks for watching, and I'll see you all next time.